أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم رب يسر ولا تعسر وتمم بالخير رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي صدق الله العلي العظيم. Dear all, Assalamu alaikum. Hope to be in good shape by the grace of Allah, but at the same time, I have heard about the sad demise of Mr. Aswad's father. All of you to please recite the Surah Fatiha and Surah Ikhlas accordingly and offer for the departed soul. May Allah give him patience and also to his family. Well, after that we come to the chemotherapy, and in that chemotherapy, part of that to be discussed today, it is chloramphenicol. Chloramphenicol. Before this chloramphenicol, you have gone through penicillins at good length and also cephalosporins covered by Professor Mariam Rashid very nicely and in good detail. Well, those medicines, they were bactericidal. You know what's bactericidal? Have a pen and a good copy with your notebook with you. So, what is cidal, CIDL, and also what is bacteriostatic? So, those discussed earlier, they were acting on the bacterial cell wall, while what we are discussing today, it is well-known drug with good history of say 70 years, so 7 decades, chloramphenicol. Chloramphenicol, this was obtained originally from one fungus, also written that bacteria, and name of that fungus was Streptomyces venezuelae. Streptomyces, myces is about the fungi. Streptomyces venezuelae. Venezuela is one country in the southern America, the north of the South America. So I obtained from there. The secretions of that fungal, they had dramatic effect to inhibit growth of a number of bacteria, and later on also found bactericidal in certain other cases. This was around 1947. 3 different years I have gone through. One is 1947, another is written 1948, and the name of the scientist is Ehrlich, E-H-R, Ehrlich, E-H-R-L-I-C-H, Ehrlich. So it's written over there that he discovered it in 1948. Then This was natural. And after that, the salt was synthesized in 1942 and 1949, and it was the first antibiotic which was synthesized. So what I remember about late 50s, say 58, 59, I remember this drug, although the childhood was there, but I remember that my eldest brother, he suffered from one and this fever and diagnosed as enteric fever, also known as just note enteric fever, typhoid, and also in our own language, Miadi Bukhar, Miadi, the temperatures for a certain period. So what I remember, the physician at that time, a well-known person, doctor, even at that time doctor was there. He was MBBS and most probably the only one or two doctors in one district, rather division headquarters, that is Bahawalpur. So he prescribed this chloramphenicol at that time. The trade name well known at that time, it was chloromycetin. Chloromycetin. Please note it down. Chloromycetin. So this antibiotic at that time it was taken as the last remedy if to treat a patient who was declared as suffering from this enteric fever. This enteric fever, also known as in technical language salmonellosis, salmonella, for the type salmonella, for the types typhi and salmonella paratyphi. So also known this enteric fever salmonellosis. So this chloramphenicol, even at that time, it was taken as the last remedy. So the temperature, still it is very effective, although it is among the toxic drugs and reserved drugs. So the temperature that subsides in say 48 to 72 hours. Note down. Very effective. If it is enteric fever, the temperature that goes to and comes to the normal line within 48 to 72 hours. It's also written, if the temperature is not responding, say for 5 days, the drug should be left. Just please note it down. It shouldn't be continued. So I remember my brother, he got well by the grace of Allah. And I have another experience about this chloramphenicol. Even while giving number of medicine to my younger son, who was suffering from tummy upset, and there was diarrhea and different medicines were prescribed. But I took him to one pediatrician, well-known pediatrician, Professor Sardar Alam at Bahawalpur. So he prescribed this chloramphenicol. I'm talking about say 83, 84, 1983, 84. And it was so effective. So he got well by the grace of Allah. Chloramphenicol. As you know, we people over here, number of medicine they are brought from outside. These are tested upon us. So chloramphenicol, it was declared dangerous for the reason you might have already gone through it in your previous classes, well known two toxic effects. One was the bone marrow depression, and there was aplastic anemia. Note down if you are not familiar with it. Please, all. Aplastic anemia. You know, when bone marrow is depressed, number of other effects will come on the blood picture. So, for that reason, this was taken out of market, I remember. Another important effect, toxic effect, for which this drug was, that was on the babies. So you are also familiar with the syndrome, gray baby syndrome, gray baby syndrome. What happens in that? The infant that stops sucking and this milk, and that becomes flaccid. There is cardiovascular collapse, and the color that becomes gray, and it's rapidly killing. It is rapidly killing. So it's related to the absence of glucuronide in infants. So the toxic effects they will appear. Another toxicity is also that it has got an injuring effect on the liver. So anyhow, this is something about the basic introduction. Why was it taken out of market, but still prescribed by certain other setup? We come to the next thing about the structure. The basic structure, you have to compare all those. Say the basic structure of penicillin, basic structure of cephalosporin, it must be there in your mind. So the basic structure of this very drug, it is a derivative of dichloroacetic acid. Derivative of dichloroacetic acid, and also it contains one ring, that is nitrobenzene ring. Nitrobenzene ring. And also please note down, it is the LIVO form of that structure which is biologically active. LIVO form. Please just note it. Then about it is the first slide, I take more time on it. Then about the mechanism of action, before that learning objects, why we prescribe it. Then antibacterial spectrum, just for your information, as concerned the mechanism of action. This drug, it acts on the protein synthesis. It acts on the protein synthesis, that is 50S ribosomal level, 50S ribosomal level. I'll show you later in the slide. So this drug, chloramphenicol, it is bacteriostatic originally. It is bacteriostatic. But in some of the bacteria, I'll mention it later on, it is also bactericidal. And just there are around 3 bacteria where it acts as in general. Another information about chloramphenicol, it is broad spectrum. This drug is broad spectrum. So for the reason being broad spectrum, this was misused. So what the quacks they did, they used it for a number of diseases, and as the patient they recovered, so this was misused, and so the resistance that developed. It is broad spectrum. You know what's broad spectrum, note down. Effective against gram positive, effective against gram negative, then against aerobic bacteria, then anaerobic bacteria, and like that. So wide bacterial antibacterial spectrum is there. I'll show you in a minute. If you think about the toxicity you have been shown, let us go to the next slide. What is written over here? These are nicely arranged by your teacher, Dr. Mariam Pracha, and I am here to elaborate. Here you see the learning aid. You were told in the previous lecture where the drug should be given and where it should not be given. Learning objectives. What should be your approach? There are two types of approaches. One is empiric, you were told previously, and the other is empiric. One is rational, based on reasons. So what you are supposed to know, where to give this or where not to give this. What toxic effects may be appearing there. What drug interactions may be there, and like that. Over here you just see also how the drug is acting. There is one beautiful picture later on, we will come across it, and that picture that's covering the protein synthesis inhibitors. So these drugs are acting like another broad spectrum, typical broad spectrum, the tetracycline you will study. You will also study erythromycins or the macrolides, not on macro and large, big structure. Mechanism of action I show you. Then another very important thing, why the resistance develops. Then how many bacteria they are covered. Number of bacteria, you have this broad spectrum, they are being covered. So to make it easy, what you have to do, keep those bacteria which are not susceptible. I'll tell you later on. As it is broad spectrum, so number of bacteria and these pathogenic microorganisms, they are being, their growth is inhibited or they are being killed. So what you have to remember, what are not being affected by it. So then the clinical application, if you know the bacteria, names of the bacteria, try to coordinate that. This one is the bacteria and this would be maybe the disease. Therapeutic uses. Other for names for therapeutic usage, clinical usage, just note down. Clinical usage. Clinical applications, right, and you're in practice. Then the toxicity. About the toxicity, what I tell you, determine how the toxicity you will deal. Acute toxicity, then subacute toxicity, then chronic toxicity. Just note down, please. You should know what would be the effect when it's given. So after that, this is one very common question, what is gray baby syndrome and why it occurs, and at the same time another thing is the aplastic anemia, although rare but very dangerous. You should also not given over ever. So drug interactions are very important because a number of enzymes are being inhibited by this chloramphenicol. Chloramphenicol is something very common, and you are asked about it in Viva, or it may be there in your MCQs like that. It has got its effectiveness and is something very common medicine for your academic purpose. Next week. Introduction. Again here, it's just repetition. That what's that? Streptomyces venezuelae. Venezuela is a country you have been told. Streptomyces, mycelium, it's the fungi, streptomyces. So from there, secretions obtained and they were effective. So in 1947, this was isolated Venezuela. So from a soil sample, those fungi are on the soil, in the soil or outside the soil. Hyphae are there, like typical fungus structure. Then you have also been told in 1948, 1949 or whatever, name of the scientist you have been given early. So this was the first to be synthesized. It was first way and practice. Then about the spectrum, it's covering number of bacteria, and again I would like to say you should know which of the bacteria or the pathogenic microorganisms they are not being covered. This is brief introduction. Then chemical structure is crystalline and it's neutral. Very important, it's stable compound. If you don't make a solution of, you don't add water to it or you don't make a solution of it. So it's stable for, say, it's a very long shelf life. Not all, very long. But once you make it, then you have to use it within, say, you have to keep it in room temperature or in refrigerator. So be used within few days once you reconstitute it. It's soluble in alcohol, but the water solubility is poor, so you have to shake the bottle. Then it's written is a bitter, then the structure is there, you see the nitrobenzene ring, and it is the liver for dichloroacetic acid. Basics should be there. Certain salts are being formed. Yes, it is for enteric fever, as you know, enteric, as the disease is there in the gut, so better given orally. This is why a question. Why given orally? So here you see dichloroacetamide. So it's the liver form which is more important. Various salts are being formed even for intramuscular use, but the main use is in case enteric. It should be given orally. Note down, or oral. OS. PO. Then kinetic. Routes of administration, it's written over here. Orally, you have been told. Then also written over intravenous. Number of various preparations are there for its application for its topical use. Used in air, maybe on the skin, at a number of places, even in veterinary side, very widely used. Topical use is there. Here you see one injection is like sodium succinate. Sodium succinate on right floor side, sodium succinate. Then capsules. One common thing you must keep in mind, mostly these antibiotics, they are usually say around 250 milligram and usually given 6 hourly, maybe 8 hourly, maybe 12 hourly. Here you see also airdrops. The airdrop, chloramphenicol, also combined with other steroid. You have already studied steroids. So these are usually cheaper to the extent you may discard it. So the medicines are not so cheaper. So it's something very among the cheaper drugs. As previously you have studied the cephalosporin, they are expensive. So So economy, you must keep it in your mind, being my students. Then about the chloramphenicol, prodrugs of chloramphenicol. These are the salts: chloramphenicol palmitate, palmitic acid ester of chloramphenicol. It is tasteless and thus intended for pediatric use. Previously you have been told these are bitter salts. So over here this palmitate is tasteless and better tolerated by the children. The ester is hydrolyzed in duodenum by pancreatic lipases to provide the active form. The ester is hydrolyzed in duodenum by pancreatic lipases to provide the active form. Yes. Here, prodrug. What is prodrug? Students should know. Please note down, especially the newcomers. Another salt is chloramphenicol succinate. It is water-soluble sodium salt. Wherever there is some sodium, you have to be very careful where to give the sodium salt and where not to give the sodium salt. Just please note it. Water-soluble sodium salt of the hemisuccinate ester of chloramphenicol. It is for intravenous administration. Chloramphenicol is used at a number of sites in number of diseases you will come. Here this structure is given, then estrase acting on it, estrase enzyme, and chloramphenicol is being released. Palmitate, chloramphenicol, estrase enzyme. Then please go to the next. Those written over here, something very important about the milligram per kg. Written over 50 to 100 milligram per day. As whenever the medicine is given to the children, you have to titrate it. So something very delicate in pediatric medicine or medicine given to the children. So per day. And what's the standard weight of a person? And let it be also in your mind, say about 140 pound or around about 70 kilogram. Note it down. It may be asked in your standard. Here you see then the next line. The drug is rapidly and completely absorbed. Something very important. Rapidly and completely absorbed. It is lipid soluble and it penetrates cell membranes readily. Next, distribution. So well distributed in body fluids, it reaches CSF. Over here, when it's going to CSF, whenever there is meningitis or like that, so this medicine was given in combination with other drugs, in combination, noted down. Here in the second line you see accumulate in brain tissue. So in the brain abscess it may be given in combination. Brain abscess around is another. The drug is present in bile. It goes into milk. So whenever a drug is going into milk, you have to be very careful in case of nursing mothers. And it crosses placenta. Again over here, the drug is crossing, so who will be affected? Then another thing written over, aqueous humor. So chloramphenicol eye drops are very common and very cheaper. You've been told earlier. After subconjunctival, here written over here is injection. Elimination and the primarily through the liver, and it is the glucuronide formation which makes it inactive, excreted in urine by filtration and secretion. While you are studying you have to compare with the penicillins and the cephalosporin. They also filtered and they also secreted. Like that is also going to kind of same process. Small amount excreted in bile and feces, those need to be adjusted. Not only here, whenever the main part of a drug is excreted through kidney, so the renal function must be there in your mind. And also in hepatic failure, the dose is to be decreased. And how the drug acts, mechanism of action. You have to compare with the previous antibiotics, the penicillin, cephalosporin. It is already mentioned that it is protein synthesis inhibitor in bacteria. And in lesser extent in eukaryotic cells. In the normal cells, it's not that very dangerous, not effective method. It penetrates bacterial cells by diffusion. Here it is facilitated diffusion. I have also said. Through diffusion it goes into the bacterial cell. And it's binding to the 50S ribosomal subunit and it is reversible, note down, reversible near the binding site for the macrolides and clindamycin. This picture will be shown to you inshallah. Here one enzyme is very important, peptidyl transferase. Very important. This enzyme is inhibited. When this enzyme peptidyl transferase is inhibited, though at that place the amino acid addition to the growing peptide chain that will be interfered. Peptide bond formation will be inhibited. Note it down. This enzyme is something very important. Peptidyl transferase. In amino acid incorporation into the growing peptide chain that is inhibited. Please note it. Concentrate on it. Here is one beautiful picture. You have to draw it by yourself. How the transferase site on right side there is messenger RNA template. At lower it is 30S, at upper level it is 50S ribosomal level. A site is the acceptor site, B site it is the peptidyl donor site, where on left side nascent polypeptide chain is shown. So there is interference at that. You have to draw this picture and something very important and number of not only the chloramphenicol written over here, that acceptor side and the donor side in between is acting, and it is the peptidyl transferase which is inhibited. Just please have a photo of it and draw it yourself. It's important from your examination point of view. Then it is written that it is the mitochondrial protein synthesis in mammalian cells especially. In erythropoietic cells, perhaps because mitochondrial ribosomes resemble bacterial ribosomes. Whenever you are giving chemotherapeutic agent, you have to compare it that if the drug is acting on the pathogenic microorganism, is that has got any harmful effect or any other effect on the mammalian cell. One must have compared next. Resistance is something very important, not only here in case of penicillin, in case of cephalosporin, resistance over here. I mean, how the bacteria or the pathogenic microorganisms, their growth is not being stopped. Here you see, I mean, the drug cannot pass. You have gone through it, that it is the diffusion. I mean, the drug cannot pass through the membrane, reduced membrane permeability. Then, bacteria, they are producing one enzyme, that is acetyltransferase, especially over here, chloramphenicol acetyltransferase. This is a plasmid encoded enzyme that inactivates the drug. So drug is inactivated by this enzyme, bacteria over here. You see previously drugs they were producing and those and certain enzyme in case of penicillinase, and in case of cephalosporinase. Over here they are producing one enzyme, acetyltransferase. So they are inactivating the drug. Another thing is there is mutation at the 50S ribosomal subunit level. On right side is picture. You see flux is influx, resistance, why the resistance is there, and draw this picture so that you know why the resistance develops to the chloramphenicol. The number of bacteria there, you have been told is broad spectrum. It's broad spectrum. And in general it is bacteriostatic, in just in few cases it is bactericidal, and active against aerobic and anaerobic. You have been told about gram-positive. Main indications written over, say the salmonella, you have been told. Shigella, what disease is there with Shigella? Note it down. It is also known, that disease is known as shigellosis. Note down, please. You may be asked later on. Shigellosis. Then Enterococci special physium. Then very important, E. coli. E. coli noted down. It will affect number of sites. And another very important, it is about cholera. What is cholera? HAZA, Vibrio cholera. Then another indication in the rickettsial diseases. Rocky Mountain fever like that, typhus fever, rickettsial disorders. Just note it down, please. Over here, the bactericidal activity. And these bacteria, Haemophilus influenzae, Neisseria meningitidis, Streptococcus pneumoniae, Bacteroides. Just please note it down. Over here it is bactericidal. Influenzae, Neisseria meningitidis, Streptococcus pneumoniae, Bacteroides. Next. Indications. I mean, few of the diseases I have been told earlier. A number of other diseases indications are also there. So main indication as reserve drug, if the safer drugs are not to be given and the fever is not responding, then you have to give this. Another thing very important is someone, as you will go through this tetracycline. This is one group of antibiotic. And cholera is not being treated by tetracycline, then chloramphenicol is effective. Also written over here, brain abscesses, you have been told, with staphylococci, then bacterial meningitis. Here you have to give a combination of medicines. Then anaerobic infections, say they are intra-abdominal infections. Therapeutic uses, number of uses are there. They are used in high infection, they are used in external infection. infection. Rickettsial diseases. Here you see when there is scrub or recruitment typhus, Rocky Mountain spotted fever, and Q fever. These are different rickettsial diseases. And another indication is brucellosis. Then eye infections uh, are, very susceptible to it. If there is bacterial conjunctivitis, very cheaper drugs. Therapy with chloramphenicol must be limited to infection for which the benefits of the drug outweigh the risk. This is something basic principle. You have already been told about it. Whenever you are going to give a medicine, you have to weigh you have to compare the risks, you have to compare the benefits, and you have to compare these benefits with the potential toxicities of the medicines. Mind it. When to give again, when other antimicrobial drugs are available that are effective and potentially less toxic, then when not to give. Chloramphenicol, when the safer drugs are there, better to be given it. Nowadays, say for salmonellosis, ampicillin, amoxicillin, ceftriaxone, number of drugs, they are available and it is kept out of market. Toxicity, very important. Aplastic anemia for which the drug was taken out. But I have gone through the literature. Then the incidence is 1 in 30,000, what I remember, aplastic anemia. When the bone marrow is depressed, so number of effects will appear there, and you must remember few of them. Rare side effects. This aplastic, it is written there, it may be idiosyncratic. This word idiosyncratic is also important. Idiosyncratic. Just please know what is idiosyncrasy. Then this occurs. Another thing, maybe even with the first dose, or even it may be given, say, the prolonged use, or bigger dose is given for a longer period, and there may be genetic predisposition. It may be genetic. Again, written over here, this toxicity is very fatal and it is irreversible. And the highest risk written over here is with the oral capsules and lowest with the eye drops. The risk of aplastic anemia doesn't contraindicate the use of chloramphenicol in situations in which it is necessary. If at all, the other drugs are not working, so it can be chloramphenicol may be given. The drug should never be used over in undefined situations or in diseases readily, safely, and effectively treated with other antimicrobial agents. Next one, after the aplastic anemia, again we come to the similar type, bone marrow suppression. And when the bone marrow is suppressed, red cell formation that will go down. And there will be anemia, maybe leukopenia, thrombocytopenia. It is observed with the use of large doses of chloramphenicol. And when it is prolonged treatment or both the conditions are there, large doses and prolonged treatment. Then the next one, gray baby syndrome, something was told earlier. In the neonates, something very rapidly killing. So if they are given relatively larger doses. So what will happen? They may be vomiting, flaccidity, temperature will go down, cyanosis, loose green stools, irregular rapid respiration, and ashen gray color. and it's something very dangerous and very rapidly fatal. Here written over gray baby in case of gray baby syndrome, the dose must be monitored. Dose must be monitored if at all it is required. Written over here in premature infants, it is 25 milligram per kg per day in divided doses. Then effects on the gastrointestinal GIT. Here one thing you must note down. Whenever these antibiotics they are given to weak people, weak patients, or so there may be super infection. So one has to be very careful. GIT disturbance, among the GIT disturbance, unpleasant taste, nausea, vomiting, maybe diarrhea, blurring of vision, digital paresthesia, digital, rare it is. In children may latent over here maybe optic neuritis and fungal infection. Here you see the candidiasis. Candidiasis is very important. Candidiasis. Hope you might have seen certain patients of candidiasis. It may be oral, it may be vaginal. Then hypersensitivity reaction is uncommon and it's something this hypersensitive allergy to the penicillin or cephalosporin. That's something very important. So there may be macular or vesicular rashes like that, and maybe angioedema or urticaria. Drug interactions very important. So if this drug microsomal cytochrome P450 that's inhibited. Cytochrome P450 that is inhibited whenever cytochrome P450. The other drugs which are metabolized by this enzyme, their life that will go and that will get prolonged. Warfarin, dicumarol, phenytoin, chlorpromazine. At least remember 4, 5, please. The drug interaction again, phenobarbital and rifampicin. Acute administration shortens the half-life. You see this phenobarbital, it is enzyme inducer. So it will have effect on chloramphenicol. Rifampicin also written over. Another important thing, you should keep it in your mind that the bactericidal drugs and the bacteriostatic drugs, they are generally not combined together. Here written chloramphenicol antagonizes the bactericidal effect of penicillins and aminoglycosides. Something very important. Note down, bactericidal drug and bacteriostatic should not be combined in general. Here is one clinical scenario, a child, a 2-year, hospital. He has taken pills that a parent had used for bacterial dysentery when traveling outside the United States. The child started vomiting for more than 24 hours, had diarrhea with green stools, now lethargic with an ashen color. It's typical picture. Other signs symptoms include temperature will go down, hypothermia, hypotension, cardiovascular collapse, abdominal distension. So written over here, name the drug molecule, the cause of this problem and write on its mechanism of action. Very common question. This is clinical scenario. Then thank you very much. If there is any question that comes in your mind, you can just uh, send us the message and we will respond. All my colleagues, they are working round the clock. They are listening to your problem. Inshallah, you will give us very good result by the grace of Allah. Even last year, a very one of our students, I know the last name of that uh, girl, Mustafavi. She came up and got position, and I hope any one of you, rather more than you, you will also give us the same response. Inshallah, Khuda Hafiz.